Hello, I'm Dr. Collins. Have you ever found yourself confused by the terms diverticulosis, diverticular disease, and diverticulitis? Then you are not alone. These terms are often used interchangeably, but in reality they describe very different conditions with distinct treatments. Knowing which condition your patient has holds the key in managing it properly. Alright, let's start clarifying this confusing topic with some definitions. You'll have to pardon my poor drawing skills here, but here's a picture that hopefully reminds you of healthy, normal bowels with the small intestines in the middle, framed by the large intestine around it. Now, diverticulosis simply refers to the presence of these small outpouches called diverticula along the gastrointestinal wall. These pouches most commonly occur in the colon along the gastrointestinal tract, but especially in the sigmoid colon due to the high intraluminal pressure in there. The presence of diverticula, i.e. diverticulosis, isn't usually a problem in its own right, and it is a very common condition, especially as people age, affecting over 50% of people over the age of 60 in the Western world. This condition occurs mainly because the Western diet isn't typically rich in fiber, which therefore causes increased pressure in the colon due to constipation, obesity, likely a multifactorial problem, and the pressure starts creating these bulges out at the weak spots of the bowel to relieve pressure. Most people with diverticulosis have no symptoms, and during colonoscopy, the colon usually looks perfectly fine except for these little outpouchings. However, the worry is that the diverticulosis may progress to diverticular disease. Now, diverticular disease is when these outpouches start to cause symptoms like abdominal discomfort, bloating, or changes in bowel habits, which we will explore in a lot more detail and compare and contrast in the next slide. But the important point here is that even though there is some symptoms, there is still no active inflammation or infection. And structurally, the bowel looks similar to diverticulosis during colonoscopy, but at cellular level, the colon wall may start developing some thickening or muscular changes due to a combination of structural and functional changes. Diverticular disease is quite an intermittent problem, and we'll come on to its management in a lot more detail in a moment. However, the main worry with diverticular disease is that it may further complicate and become diverticulitis. So, last but not least, diverticulitis is when one or more of these diverticula, these outpouches, becomes inflamed and or infected. And your patients with diverticulitis will be very symptomatic due to a number of reasons, such as bacterial overgrowth within these pouches or microperforations, because further increased pressure within the lumen causes significant inflammatory changes to take place. And this can cause very severe complications such as abscess formation, fistulas, bowel obstruction, and even perforation. What we have discussed so far in this table hopefully gave you some clarity about each of these terminologies from a pathophysiological point of view. However, the most important thing in clinical practice is having a practical approach to distinguish clinical presentation swiftly and accurately so that you can institute the correct management for your patients. Which brings us to this table, in which we will explore the presence and absence of key clinical features as guiding tools. So let's have a look. You might have noticed from the previous slide that the presenting complaint of these three conditions will be extremely different than each other's. Therefore, the differentials that you will bear in mind whilst evaluating each clinical presentation will be different. So let's start with diverticulosis. As we mentioned earlier, diverticulosis is a fairly asymptomatic condition. No fevers, no abdominal pain, no change in bowel habits, and no systemic upset. And it is usually diagnosed as an incidental finding in colonoscopies. The second most likely presentation that might lead your patient to a diverticulosis diagnosis is painless rectal bleeding in an otherwise well patient. But remember, there is no infection or inflammation in diverticulosis. This painless rectal bleeding simply occurs due to a blood vessel, usually a branch of vasa recta that runs adjacent to a diverticulum, becomes exposed and erodes as these outpouches are formed. So the bleeding is due to a structural reshaping of the colon rather than an inflammatory process. However, remember that when a patient presents with painless rectal bleeding, the most likely differentials will be benign, such as internal hemorrhoids, colonic polyps, or diverticulosis itself. But because colorectal cancer may also present with painless rectal bleeding, you will have to do a whole set of workup, which often results in patients having colonoscopies, which then goes on and identifies the diverticula. Once the diverticula are identified and the patient has a diagnosis of diverticulosis, the management primarily focuses on prevention of complications. The key preventative measures are acquiring a high-fiber diet, staying well hydrated, and getting regular exercise, all of which collectively keeps the bowel movements regular and reduces the pressure in the colon, which lowers the risk of developing more diverticula, and the condition therefore doesn't progress to diverticular disease or diverticulitis. That's the main objective. With diverticular disease, the patients may still present with some rectal bleeding. Again, because of the same underlying issue as diverticulosis without infection or significant inflammation. Because of this, colorectal cancer will still remain as the key differential that you'll need to rule out, but more often than not, patients with diverticular disease presents with a few weeks or months history of colicky abdominal pain that comes and goes, which therefore will bring into your mind more intermittent conditions as the other possible differentials for diverticular disease, such as inflammatory bowel disease or irritable bowel syndrome. And with diverticular disease, the pain is mainly in the left iliac fossa. Remember, this is where the sigmoid colon is and where the majority of diverticula are usually formed because of the highest intraluminal pressure. And this will often be on a background of some sort of chronic change in bowel habits in the form of constipation. Patients will be fine in between episodes and they will certainly not have any fevers and no other systemic features such as tachycardia, rigors, etc. Management of diverticular disease involves the same management of diverticulosis with the lifestyle changes we talked about. However, patients will also likely need some additional symptomatic treatments such as laxative to ease bowel movements and antispasmodics that can help relieve cramping. And also, it is important to avoid non-steroidal analgesics such as ibuprofen, naproxen, etc. with these patients, as they can increase the risk of bleeding and worsen diverticular disease into diverticulitis. So, last but not least, diverticulitis has a very distinct presentation compared to diverticular disease and diverticulosis. These patients' main presenting complaint will be very severe abdominal pain, again, mostly in the left iliac fossa, which will be consistent with the findings of an acute abdomen this time. So the tummy of the patient might be very tender, the patient may be guarding, and your key differentials will therefore be at least equally acute emergency type of issues, depending on the age and the sex of the patient, such as complicated inflammatory bowel disease, ischemic colitis, ovarian torsion, or atypical appendicitis. And remember, these patients will be quite unwell because there is infective and inflammatory process taking place here. And therefore, they might have fever, they might have other systemic features such as tachycardia, shivers, rigors, nausea and vomiting, etc. And depending on the severity, because remember diverticulitis might progress to some more severe complications, as we discussed previously, such as abscess, fistula formations, obstruction, perforation, and sepsis, they might have a mixture of symptoms such as constipation or diarrhea due to overflow from obstruction, plus and minus rectal bleeding. Management of diverticulitis very much depends on the severity of the presentation. In cases with mild systemic upset, where the patient is able to eat and drink and has no symptoms of peritonism, treatment can be trialed in the community with oral antibiotics such as coamoxiclav, if not penicillin allergic. However, patients with significant pain, systemic features, or signs of complications will require hospital admission for observation and for intravenous antibiotics. A CT scan is typically used to confirm the diagnosis and assess for complications. In severe or complicated cases, surgical intervention may be necessary. There we are, here's our table complete. This might be a good place to stop the video and take a screenshot of this table for reference. I hope it will be useful. Thanks for watching. If you like this video, please like and subscribe. You can explore more free videos and access our free question bank on our website. Good luck!